In this presentation, we will talk about, do we care about fibrinolysis? We'll talk about the antifibrinolytics, cryoprecipitate, and prothrombin complex concentrate, and thrombosis. The objective is to look into the incidence of fibrinolysis in liver transplantation, to talk about physiology and pathophysiology, and discuss the impact of antifibrinolytics, cryoprecipitate, and prothrombin complex concentrates on patient outcomes and the risk of thrombosis. So first, we will look at the incidence of fibrinolysis in liver transplantation. This image on the right is from 1985, the early stages of liver transplantation, and it shows that fibrinolysis can occur in any phase. Stage 1 is the dissection phase, stage 2 is the anhepatic phase, and stage 3 is the reperfusion and post-reperfusion phase. Fibrinolysis is most common in the anhepatic and reperfusion phase. And around that time, it was reported to occur in about 30 to 50% in liver transplantations. This study from 2023 looked into the incidence of fibrinolysis and mainly compared donation after brain death versus donation after cardiac death patients. 535 patients were included in the study at post-reperfusion. Overall, 3.9% had fibrinolysis. The main occurrence of fibrinolysis was in donation after cardiac death with 27.8%. Donation after brain death was in 3.1%, and no patients had fibrinolysis who had a living donor living transplantation. Fibrinolysis was treated in 3 different ways. 6 patients did not receive any treatment. 12 patients received cryoprecipitates, and 3 patients received cryoprecipitate and tranexamic acid. In all cases, fibrinolysis resolved within several hours. This study from 2018 looks into the incidence of fibrinolysis in living donor living transplantation. All patients who received antifibrinolytics were excluded from the study. Total of 110 patients were included, and they defined the clot lysis index anything less than 85%. Looking into the figure on the right side, T1 is the time immediately after the anesthetic induction. No patient had fibrinolysis. T2 is the end of the pre-anhepatic phase, and 4.5% of patients had fibrinolysis. T3, this is the time when fibrinolysis occurred more often. 1 hour after the anhepatic phase, 18% of patients had fibrinolysis. T4, the most common time of fibrinolysis, is 5 minutes after reperfusion, and 71% of patients had documented fibrinolysis. T5 is 1 hour after reperfusion, and nearly in all patients, fibrinolysis resolved on its own, and only 1 patient, which is 0.9%, had fibrinolysis. T6 is 3 hours after reperfusion, and in all patients, fibrinolysis has been resolved on its own. Fibrinolysis in the study, when they looked into other data, was not predicted from pre-op demographics and coagulation profiles. This study also found that the intra-blood loss was greater in the fibrinolysis group. They did not comment on whether the blood loss was because fibrinolysis occurred or fibrinolysis occurred because of more blood loss. This study from 2015 shows self-limiting fibrinolysis in living donor living transplantation. And 84% of patients develop fibrinolysis after reperfusion plus 5 minutes. And fibrinolysis was defined based on the ROTEM as the maximum lysis time over 15%. The condition of fibrinolysis was reversed after 30 minutes without any need for treatments. When they looked to an ATEM analysis on the ROTEM, it fully reversed the fibrinolysis. No significant bleeding was observed during this period in all of the cases. Now we will talk about the physiology and pathophysiology of fibrinolysis. Liver transplantation patients have a higher TPA-A tissue plasminogen activator level and a greatly reduced plasminogen activator inhibitor activity, PAI. This is one of the reasons why they are more prone to fibrinolysis. When we look at figure 1 on the left side, we can see the difference level at different stages in liver transplantation for the TPA activity. The reference range for a normal patient for TPA activity is marked as an orange arrow, and it's about 0.2. This graph shows patients with minimum coagulation abnormality and severe coagulation abnormalities. Even in patients with minimum coagulation abnormalities, the baseline TPA activity level is about 10 times higher compared to a normal person. For patients with severe coagulation abnormalities, it's about 20 times higher, and this is one of the reasons why they're more prone to fibrinolysis. This activity goes up during the reperfusion phase and slowly comes down afterwards. It reaches a level more than 40 times higher than a patient without liver disease not undergoing liver transplantation. On the right side, looking at figure 2, we can see the plasma PAI level during liver transplantation. The reference range is marked all the way up in an orange arrow, and it's 13. Patients with even minimum abnormalities have almost a half-time lower activity of PAI, and patients who have severe abnormalities have almost a 6 times lower level of PAI activity. This means the plasminogen activator inhibitor cannot inhibit TPA, leading to a more prone condition of fibrinolysis from TPA. This study looked into the cause of the high TPA activity, and in order to do that, they compared orthotopic liver transplantation with heterotopic liver transplantations. And if you see, the red box is the part of the anhepatic phase. And in orthotopic liver transplantation, we see a very high increase in the TPA activity. This does not happen in heterotopic liver transplantation. The main reason is, even though you have a cirrhotic patient, there is liver function, and as long as the liver function remains and there is an existing liver, the balance of TPA and PAI levels each other out, does not increase the risk of fibrinolysis. However, in orthotopic liver transplantation, removing the liver causing an anhepatic phase is the main reason for the high TPA level activity, and ultimately a higher risk of fibrinolysis. So now the question is, do we need to treat fibrinolysis? We have seen that fibrinolysis can resolve on its own, and almost in all cases in living donor living transplantations. If we give a blood product that's very close to whole blood, meaning RBC combined with FFP, either platelets or crystalloid transfusion in a 1:1 to 250 cc ratio, we might be sufficiently limit fibrinolysis because it can replace all the factors, and it also contains PAI, which inhibits TPA and antiplasmin. However, if fibrinolysis still persists, an antifibrinolytic can be an option. Now we will look into the different types of antifibrinolytics and the mechanism. There are two big groups of antifibrinolytics. One is the lysine analogs, and the other one is the serine protease inhibitors. In the group of lysine analogs, there's epsilon amiporic acid or amicar or tranexamic acid. The chemical structure of lysine and amiporic acid and tranexamic acid is very similar, and that's why they act as a lysine analog and very specifically to inhibit fibrinolysis. Tranexamic acid is about 7 times more potent and has a longer half-life than amicar. In the second group, the serine protease inhibitors, there's aprotinine. It's a naturally occurring serine protease inhibitor. It has a complex chemical structure and it inhibits fibrinolysis by forming a reversible complex with plasmin. But unlike the synthetic lysine analogs, aprotinine does not only inhibit fibrinolysis. And due to its wide-acting serine protease inhibiting activity, it also has an effect on platelets function. It has an effect on anti-inflammatory processes, and in high doses, it becomes an anticoagulant. Now we will look into several outcome studies. And I like to discuss the limitations when we look into outcome studies. Outcome studies, we look into an intervention like giving some antifibrinolytics. We do not look into what's happening with the blood itself. There's no viscoelastic testing like ROTEM or TEG involved, but we look into the outcome of blood loss, the amount of transfusion, or thrombotic events. So most likely outcome studies contain unidentified biases and confounding factors. And while there might be a statistical association between what we observed and there's an outcome, the clear scientifically proven correlation is not well established. And those are important things we have to consider when interpreting outcome studies. This study looked at the outcome of amicar, tranexamic acid, and aprotinine. They included 23 studies, including randomized controlled trials and controlled trials with about 1,400 patients. Aprotinine and tranexamic acid reduced transfusion requirements. They did not find any increased risk of hepatic artery thrombosis. There was no increased risk of venous thrombotic events or mortality. This study from 2024 actually shows the opposite. They looked into 779 patients. The estimated blood loss was about 3 liters, and they were administered tranexamic acid in about 1.4 gram plus minus 0.7 as an average dose in about 33% of the patients. This study showed that giving antifibrinolytics was not associated with the change in intra-op blood loss. It was not associated with intra-op RBC transfusions. It was not associated with post-op RBC transfusions and any occurrence of thrombosis. Additionally to those 2 conflicting studies, we have case reports that reports about fatal thrombotic complications in the use of aprotinine during liver transplantation. These patients received aprotinine as a loading dose and infusion, and during the phase of liver transplantation died. On autopsy, they showed massive thrombotic event. On the right top, that's the anastomosis site of the portal vein that shows significant thrombosis. We have some thrombosis in the heart, in the brain, in the pulmonary arteries bilaterally, and inside the heart next to the PA catheter. Somehow the TEG did not reveal any significant signs of fibrinolysis, hypercoagulation, or coagulopathy. Next, we will talk about cryoprecipitate, fibrinogen concentrate, and prothrombin complex concentrates. When we look into the composition of cryo is made of FFPs. FFP is being frozen, it's being thawed, and any fluid is being extracted. So anything that's not soluble will be left behind as cryo, which is mainly fibrinogen. Additionally, there are some other factors like factor 13, von Willebrand factor, and factor 8. When we look into the absolute amount, FFP has far more fibrinogen than cryo, and it also includes all coagulation factors. So FFP is the better product in terms of absolute components compared to cryo. The main reason why we give cryo is mainly because of the volume, and patients who have restricted volume or fluid overloaded may benefit from cryo, despite taking into account that it might not solve the entire coagulation problem because of the limited number of components in cryo. The next product we're going to talk about is the prothrombin complex concentrate, PCC. PCC on a meta-analysis showed it can cause thrombotic events, and 3-factor PCC had an incidence of 0.7%, 4-factor PCC of 1.8. PCC contains activated coagulation factors and most likely have a risk of thrombosis because activated coagulation factors will activate coagulation. To increase safety, there have been some changes made in the last couple of years to the production of PCC. One is the avoidance of activated factors, one is to increase greater purity, and adding other components to balance off clotting and anticoagulating factors. So now it contains protein C, protein S, protein Z, antithrombin, and heparin. This is a list of available PCCs, and when we look at the 3-factor PCCs, they do not contain protein C and S and Z, and also none of them contain antithrombin 3. Compared to that, 4-factor PCCs, all of them contain protein C and S, and some of them contain protein Z and antithrombin 3 and heparin. Now we will look into some outcome studies. This study looked at 372 patients undergoing liver transplantation, and they concluded that the ROTEM-guided substitution with fibrinogen concentrates and PCC does not negatively affect mortality after liver transplantation. This study shows the opposite finding. This is a study from 2022. They looked into fibrinogen concentrate and the PCC use in about 939 patients, and it was associated with hepatic artery thrombosis, portal vein thrombosis, and IVD thrombosis with a hazard ratio of 2. It also increased 30-day mortality with an odds ratio of 4, a graft failure with an odds ratio of 3, increased intra-blood loss, and increased the use of PRBC, FFP, and platelets, increased hospitalization and longer ICU stays. It was not associated with PE, MI, strokes, or DVT within 30 days after surgery. In conclusion, fibrinolysis is mostly self-limiting, especially in living donor liver transplantation, and it's more frequent with donation after cardiac death liver transplantations. The high levels of TPA and low level of PAI have been identified as the cause. And seems like adding coagulation factors as supplementation usually does not activate the coagulation system and probably not a risk factor of thrombotic events. Looking into outcome studies, antifibrinolytics, fibrinogen concentrates, and PCC appear to reduce blood loss without increasing the risk of thrombosis. However, contradicting studies shows that antifibrinolytics, fibrinogen concentrate, and PCC does not reduce blood loss but increase the risk of thrombosis. So the final words, coagulation is a dynamic state. A close continuous monitoring combined with ongoing clinical assessment and treatment using the minimal effective dose can improve safety.